So thank you all for joining in this morning for this very important inception we are putting up for our SORMAS, the series of training sessions we'll be having. The intention is to make sure that we keep ourselves up to date as far as the use of SORMAS is concerned. So what I'm going to do is to just quickly take us through the objectives of this workshop. And then we will have a series of presentations on SORMAS. Then it will be followed by some demonstrations. One of the things I want us to also take from this meeting or this workshop is that the Disease Surveillance Department of the Ghana Health Service, we've set up a YouTube channel and we'll be sharing the link to that channel. But also, the main aim will be that we'll be putting videos there on a lot of these things we're doing. And so that at our own spare times, we can go there, watch the videos, and update our knowledge on the use of our electronic IDSR platform, SORMAS. We would be updating the case investigation forms soon. And when that is done as well, we will update you on the changes that have been made. And so this year, I want to assure you that we'll be having these trainings online quite frequently. We will also make sure that, particularly for our colleagues who are with the Allied Health Council, will get accreditation for these trainings so that you can be able to get continuous professional development points from these trainings. Now, I want to encourage, I know that online meetings, people would usually log in and sometimes go and sleep or do other things. Because this is hands-on, if we don't concentrate or focus on the presentations and the demonstrations, we may have participated but would not have benefited from it. So I want to encourage us all to give it our utmost attention whilst we go through this training. So I'm going to just quickly run us through the objectives as I indicated, and we would then take presentations from Dr. Atta and his team. I am sure I didn't introduce myself, so maybe I would. My name is Dennis Lai. I work with the Disease Surveillance Department. I'm the Deputy Director for Surveillance with the Ghana Health Service. I think there are a lot of us on the call, so it would not be a realistic expectation to expect self-introductions, but at least the presenters would introduce themselves. Hopefully they don't forget like I did when they are making their presentation. So as I said, we'll quickly go through the objectives of the training. The first one, we want to offer ourselves an overview and to refresh our minds on the use of SORMAS as the electronic IDSR tool for Ghana. Overview and refresh our minds on SORMAS use. The second one is to highlight changes we've noted as far as the use of SORMAS is concerned. So we'll highlight some of them. It won't be all, and we would also be grateful for feedback from you. Also look at key functions that can be performed on SORMAS. One of the things I've learned with, we don't know a lot of the things our smartphones can do. And so we're going to highlight some of these things that we may not be paying attention to as as users of the SORMAS platform. And then, as I said, there'll be some demonstration. And then beyond this, we'll also take some feedback from you. We'll look at some challenges you may be encountering as far as the use of SORMAS is concerned. And as I said, there will be subsequent sessions on these. We are aware that, for example, our regional surveillance officers and our regional health information officers are in a concurrent meeting at the moment, and so they may not be part. And so we would prepare similar trainings in the coming weeks so that we can all be on the same page as far as the use of the tool is concerned. So on this note, I want to look at the scope. Maybe let's quickly look at the scope. So overview, as we said, we'll look at the key functions, case entry, sample creation, which is one of the key areas of concern. And then contact creation, supervision, and monitoring, which again, supervision, because remember, electronic IDSR is just doing what we're doing manually, electronically now. So whereas those times we'll go and look at the case-based forms that have been filled and check for completeness and all those other things, our supervisors can do the same thing on the platform. And so we'll look at all these things as part of this thing. So hopefully at the end of this, we would have been well-versed with case entry, with sample creation, contact creation, supervision of case entry, and then monitoring of surveillance data. And one of the things I want to say, we know with technology, we can be able to tell who has done what at what time. And so let's be mindful of this. Let's be guided by the fact that every time we are on the platform, we are generating evidence which can always be pulled and looked at. So I think that this is going to be the scope. And without much ado, I'm going to leave or hand over to Dr. Joshua Arthur, the National Public Health Emergency Operations Center Manager, and the team to take us through the training. So once again, thank you all very much for joining. I see we are almost 500 on the call now, and that is a very good sign. Thank you, and over to you, Dr. Arthur.
And good morning, everyone on the call. Welcome to our first in a series of sessions that we hope can bring the team here at the Disease Surveillance Department closer to all of you who actually use the system and help to generate surveillance data for the country. We know the work is actually done by you, and so we are here to offer this support. So to start off, I think a few people are saying that they cannot hear. I think generally people are hearing, so sometimes maybe the challenge has to do with a network at your end, and
Hello, can I be heard now?
Yeah.
Okay, I'm speaking now, so if I can be heard. Okay, so I'm seeing a couple of yeses. Thank you very much. Thank you very much. Right. So as we said, we will look at what EIDSR is. And for EIDSR, we are talking about how we apply electronic tools to the principles of integrated disease surveillance. And that is concerned with prevention, prediction, detecting, and reporting, as well as response if there is an outbreak. Most of us are familiar with IDSR, and we are familiar with the various forms and tools that we use for IDSR. And so EIDSR is not anything new, but the attempt to do these things using electronic tools. So you are really just taking the same form and putting it in an electronic format for use. If you are going to send a document to the district office by walking or taking a car, you are now going to do that using an electronic means. And that is simply EIDSR. So we have to look at how we introduce standardized or interoperable information systems that support the rapid collection, analysis, reporting, and use of disease information and data in real time. And that is the very value of public health intervention, so that we can have the rapid question that is required. As I've tried to allude to, electronic IDSR or EIDSR tools allow us to rapidly transmit surveillance information, and that rapid transmission helps with the timely detection and response to outbreak. If there is a fire, if there's flood, whatever, we don't see that.
You are always assured that you can make copies, you can back it up, and then you can always have access to this. So that is the idea of having electronic ways of approaching data collection, storing, and all that. Then, of course, if I was writing something on a paper, once I'm done writing, if I wanted to change it, then it's a bit difficult. Erasing, changing, adding on, it's a bit difficult. However, if you are using an electronic system, you see that it's easy to go back and say, oh, I put in 10, but it's actually supposed to be 20, and it's easy to do that. If I were supervising and monitoring surveillance data, I may have to take about 20 or 100 forms coming from my various facilities or wards or districts. But if it's electronic, then it's easy to see them all at once, look for trends, check what has been written and what has not been documented, wrong entries. It's all easy with an electronic system. So these are some of the advantages that the electronic IDSR approach gives us. And so if we apply them, then we can actually begin to experience these benefits. For Ghana, we are doing electronic IDSR using the Surveillance Outbreak Response Management and Analysis System. So that's the full name meaning of SORMAS. And this system helps us to manage public health surveillance information in Ghana. It supports our case-based surveillance, which is a form of indicator-based surveillance. And then also now, it has been configured to support event-based surveillance, which is a reporting of signals and events that may happen in our communities or even our health facilities. So we use surveillance for case-based data collection. the aggregation of this case-based data, support real-time reporting or near real-time reporting. So if I put information in SORMAS now, immediately all the levels above have access to that information. So the movement of surveillance data through the system, it's almost real time. Once I'm able to input my data, sync it to the system, everyone that should have access to it gets that access or can see that information. Similarly, SORMAS is configured to support threshold setting, alert and notification. So the same way that we do threshold monitoring based on the population available, SORMAS has that ability, and these things can be activated for use. Contact tracing, so contact listing, contact follow-up, all that capacity is available on SORMAS. Then, of course, laboratory sample management, information on the sample, which lab it's going to, when it has been shipped, and then similarly, when the information or result is available, it can also be seen on the system. Then data analysis. So SORMAS would also take the data we've put in and help us with some analysis, totals by week, by period, by location, and then visualization. Because it has the capacity for us to pick geographic information system data on location of cases, on location of contacts, on location of facilities, it helps us to be able to represent that data through map analysis. And then as before, if we have signals and events, we are able to register, document what we have done about these events, signals, and then that gives us some way of following public health events around us. So our expectation, I mean, if you look at the way SORMAS works, the expectation is that staff and supervisors will regularly monitor the entries made on SORMAS. So are we doing it timely? Are we doing it completely? Are there missing details so that we can go back and check? That is the good thing about electronic system. You can always go back and update it. Staff always doing spot checks for accuracy and timeliness. So as the completeness count too low, the system allows you to just summarily see that, oh, this particular case entry, the completeness is 10%, 20%, 80%, 90%. You can just see. The system does that count for you. Do you have a disease that has been entered? And you're asking yourself, but this disease, I am not aware that it's around. Where is it coming from? Who is putting it in? What information has been put in? And also cases that have resulted in mortality. You see that if we are checking things on the system, if anybody is going to ask questions, then those type of cases likely have more interest. So what is the completeness check? What is the accuracy check for these diseases? These are things that we are expecting that staff, supervisors, and other persons in the system can do to ensure that we've got very robust surveillance data. Then we are also looking at what system at the local level, at the facility level, at the district level can be put in place so that if someone sees anything that has to be corrected, then there is a system to ensure that somebody goes back and corrects it. Otherwise, yes, we might see mistakes, but the question is who is to go back and effect any corrections. Then we also all have to know if I have a problem on SORMAS, if I have a challenge on SORMAS, where do I go to? Who do I talk to? A few times people have a problem and like, oh yeah, so I'm not using my tablet anymore. For how long? Oh, for like 6 months. Why? I don't know who to talk to. I'm not getting answers. So the expectation is that we all know who and where to get our concerns and problems on SORMAS addressed so that we can continually use the system. And that is the only time it will really be useful. Unfortunately, when you look at the data in SORMAS now, it looks like it's not being supervised. And a lot of data entry challenges, key fields left unpopulated, leading to very low completeness rates. If you look at the total IDSR case counts being submitted and you compare with what is on SORMAS, there's always a discrepancy. If you go to the lab, looking at how many samples are there for cases, you compare with what is in SORMAS, there is always a discrepancy. Sometimes cases arrive at the lab and the lab says that, well, we don't have sample information when we check SORMAS. And you go in and maybe no sample has been created or even the wrong lab has been selected on the system. And if that happens, the lab the sample has gone to will not even see the information because their access allows them to only see what has come to them. Then cases being entered late. If I were to pick the data on a particular disease as at this time for maybe last week, and I come back in a week or two, the count will be different because maybe in 2 weeks' time, someone is now entering the data for maybe 2-3 weeks ago. So you see that as you go back into the system, the data always changes because of this late entry. And so the timeliness is low. And then sometimes from the national level, from the regional level, people are saying, okay, we've seen this, we've told them to correct it. And the question is, who is going to do it? So you see that there's maybe no system or even an inefficient system that ensures that once some of this supervision flags some challenges or some errors, they can quickly be worked on. This is what we do from the national level. We try to look at the data quality for every PID week. We look at it by region, we look at it by priority diseases. And if you do the comparison, we see a lot of yellow and even sometimes red spaces, which shows discrepancy between the number the region says they've reported for that disease for the week and the number in SORMAS. These are the things that we are hoping that these SORMAS training sessions, clinic sessions can all help us work on so that we see a lot of greens and we don't even want to see reds. When you look at the data quality completeness, you see the number of cases, how many have things like date of onset all populated, age all populated, samples actually created on SORMAS, and results, and also maybe avoiding duplicates in all. So just to give feedback that these data quality checks are being done by the national team. We're encouraging our regional teams, even district teams, to set up similar systems so that we can always monitor what is in the system, give feedback, and then, of course, for us on the ground, we can quickly go back and to correct this. We need to do this. We know how to do it, so we can now do it ourselves. We want to show some of the challenges, and you can see that when you go into the system, this is, we will look at the demo. This is the case line list, if I can put it that way, that you see. And there's a whole column that talks about completeness. You can see on the system, it's giving you an idea. Even the color, I'm not happy with it, it's red. So whereas some cases are flagging 65% completeness, 30%, 50%, you have some cases 10, 15. And clearly that is a case that we want to go in, find out what is the challenge and be able to update appropriately. Data completeness. This is a session on symptoms and a whole session left uncompleted. It really would not help with decision-making on that case. So this case may come in, finally become positive, and then there's very little information that helps the system to understand the case and what to do about it. These are real cases taken off the system. So it is not that somebody is making up these challenges that we are talking about. A whole part about symptoms not completed, as we can see. Critical fields, age. So no date of birth for the system to even calculate age, or actually for us to input age if we don't know date of birth. So critical things that any data, useful data has to have. These are left uncompleted. We are looking at symptoms. So if I've put in symptoms, I'm being asked about date of symptom onset. For all of us in surveillance, we know the value of this information to know when symptoms started so that a lot of activities, even contact tracing, the rest, can all be put in place and followed up appropriately. But some of these things are left uncompleted. Sample creation. So you follow the whole case, you go to the case sample tab, and then you meet a picture like this. No sample there. The lab is done with testing and they cannot do the feedback of the sample. But the proper thing is what we are seeing here, that the sample would have been created, the appropriate lab selected, and now the system can continue with what it's supposed to do. So these are some of the challenges. A lot of us have tablets, but when you actually go around, you see that the version of the app is outdated. And once it's outdated, then it cannot connect to the mother system. And so we also see that, my SORMAS is not working. And then that's the end of it. And then feedback from a lot of our colleagues in the field shows that a lot of them have not had any training, formal training to use the platform. Some have user details and they've forgotten, so you don't have access to the user details. The person who was there has been transferred, did not leave these details behind, and now we can't use the system. We've talked about the late entry. Lab has run their sample because of the burden there too. They're also having a challenge going back now that you have entered the case to even update the system. Then, because of habit and practice, people are still filling the paper case form, then they want to transfer to SORMAS. So once I come back and something happens, another piece of work comes in, a meeting comes in, then it is never entered. It becomes a delay, and it's only maybe later that we remember to do it. But we want to encourage the practice of actually using our tablets to go to the cases, to start the data entry, and then we already have the case in the system for follow-up. Creating cases without samples. Sometimes it's forgetfulness. The whole case has been entered, but the sample has not been input on the system. Sample moves to the lab works on it, but they cannot give feedback. Then sometimes choosing the right lab. So the sample is going to the public health reference lab, but maybe Noguchi has been selected or a different lab altogether. The staff at the lab will go in, case is on the system, a sample is there, but they can't see the case because their access will not allow them to see a sample that has gone to what? Another lab. Then there is a barcode system that we put on the sample, also on the sample transmission forms, so that at the lab, because I may take 2 cases, another facility may take 2, a district may take 20. When it all comes to the lab, especially, they may be dealing with hundreds of samples. Going in to find the cases one by one takes time, it's tedious. But there's a barcode system that when they scan, it brings up the case and the sample immediately, and they can proceed to do their work. If we are not using the barcodes, if we are not aware of it, where to get it, how to use it, then this becomes a challenge for sample management and prompt feedback. And then, of course, we've mentioned the supervision of SORMAS use at the regional and the district level. And we want this supervision to even take place, especially in our big facilities where there are a lot of cases being reported. These challenges are what we have identified. And so to go forward, we are looking at structured training. What we are doing right now is to have our regional teams capacitated to be able to support all the districts and facilities there, and also have support for in-person training. But now with technology, these SORMAS Clinic series, that will be frequent and target all levels. So we want to come on to these sessions, be able to ask or put across our challenges, and then the team would help solve the problem, give explanations. And then as Dr. Lai mentioned, record these sessions put them on our YouTube channel so that at any time, any individual can access them and update themselves. And then to encourage supervision of SORMAS data entry. We know how we used to work with the paper system, and we still have the tools electronically to make that supervision even easier. So for all of us, we want to be able to supervise ourselves, for our management level colleagues to also be able to look at what is in the system and see where things are not going well, and then make inputs for correction. And then if we are using SORMAS to report and make decisions, then all of us realize that we need this data. So if I have an outbreak, if I have a weekly report, if I have a monthly report, I am going to fall on SORMAS data because I know the value of the data and I use it. It actually also means that I am committed to ensure that the data is in a good state and I can make it work. So it is important that we use the SORMAS data, and then we can all see whether it's going well and then take steps to make it work. So in short, this is just a quick background how we want to use SORMAS to support surveillance and some of the challenges for which reason we are even instituting these sessions. We would want to go on and then look at the various demos that we can do, and then take feedback from you on the call and address any pertinent challenges that you have. On that note, thank you very, very much. Okay, so if there are, I think we wanted to get a quick poll. We want to understand some of the things that our colleagues here, you either know or understand about the system. So at this point, we want to launch a quick poll. Please give us your feedback, and this would really become useful as we go ahead, so that we understand the audience that we have and how best that we can also support you going forward. So the poll is on your screens now. Please look at it, give us a quick feedback. We want to understand what your current status is, whether you've been trained, whether you've not been trained, all those things. And then we can be in a better position to support you. So we'll leave the poll on. We'll give ourselves a few minutes. We have over 600, almost 700 of us on the call. We want all of you to actually engage us in this poll, and then we can continue from here. Some of you can't see the poll. When you look on top, there is something that looks like a bar chart, column chart at the top. When you click on it, it will bring up the poll for you. If anyone is having challenge, please put it in the chat so that we can also see that. Right, so someone is saying question 3 and 4, right. It's an option that you don't use SORMAS. So for those that don't use SORMAS, please, you can go for that. So yeah, for question 3, please choose your best option. Yes, we appreciate that not everybody uses that. It's only a poll. It's a poll, so it's just to get a good understanding of the audience here. So don't worry about not having the option that you don't know. The other questions clearly help us see those who don't use SORMAS for now. So let's do our best. I think we've got, yes, just about, okay, 2/3 of us all have actually answered. So we give ourselves a bit more time and then we can get the full picture. Great, great, great. There are a few self-taught persons. Congratulations to them. Yes, so please, as I said, it's just to get an idea of what we here know. So it's not to say that this is what it is and all that. That is why we are here. All these questions will get a good idea of, it's not to test knowledge, it is to find out what people are actually doing. So please just give us feedback, especially whether you've been trained, how you got trained, and the ways in which you use SORMAS and all that. Bye-bye. So I think we showed how to find the poll. Some people, if you are not seeing it, when you look at the depends on your screen corner, you may see a small symbol of a chart, a graph, something like a bar chart or something like that. When you click it, it will bring up the poll. So for any person that is struggling to find a poll, that is how you find it.
Because I think it appears like.
Okay, Arena, I guess you are on a phone. So if you're on a phone, you have to see if there is either a small arrow for you to scroll down or sometimes even to the side. It may be a very small arrow, and so you have to attempt to scroll down or to the side so that the other questions will come. They are all a poll to one long format. So maybe depending on your screen size, you may have to do it that way. So yeah, so the whole training is being recorded and will be posted as promised on the department's YouTube channel. The YouTube channel will also be shared. We'll also attempt an email following the training. So in that email, you would have the link. Yes, it's fine. If you have not used it, you make a guess and then it's okay. Go ahead. So question 3 was updated, but it looks like the saving didn't work. So it's fine. Just pick whichever one and then we go. So knowing the version, how to find the version, it's all part of the things that we'll cover here so that we all understand how to monitor our use of SORMAS. So we have about 77% of us participating in the poll. I think at this point, and then we can continue. What we want to do next, we want to start off by having a demo on our Android app platform. And so what we'll be looking at is how the Android app interface looks like. And we will focus on being able to create a case using the SORMAS app. Later on, we will switch to the web. And as mentioned, the web, we encourage it for supervising the surveillance data we have put in the system, maybe using our we'll switch to that. So for now, we want to invite Mr. Obedofori, who is a surveillance officer at the Disease Surveillance Department. And he will be taking us through how the tablet interface, app interface looks like for those of us who have never used it. And then as a refresher for those that are very familiar with it. So we invite Obed to do that now. So the poll has been ended, so you will not see the poll anymore. But then we now want to move on to our demo. Thank you.
Thank you, Dr. Atta, and good morning to everyone. So as Dr. Atta mentioned, I would just do a quick demonstration on how to navigate the interface of SORMAS to create a case where you can locate that case add button. Then later we'll look at sample management, specifically how to create a sample, and spend time to look also at how to check for results. And later on, we will look at contact management in the event of contact tracing for some diseases. So SORMAS app will be installed on your tablet among the other apps that you may have on your tablet. So to locate the app, you open your tablet, then you go to the apps on the tablet, then locate where SORMAS has been installed. So as you can see on my tablet, when I went to the app menu, we can see SORMAS is the last application that has been installed. So you click on it just as we have for every application that you may have. So the interface will open for you. If you look at the top left, we have the hamburger menu, which gives us the access to the tabs. So it's collapsible. When you click on it, at the top left corner, those three horizontal lines is what I'm referring to. If you click on it, you have some tabs, which gives you specific functions on the system. So you may see the tax, cases, MS, ERS, contacts, event, samples, immunizations, and report. All these are specific tabs that allows you to perform functions in the system. Then at the top right corner, we have the plus sign, which is actually the case, the add case button. And then you can see those three dots, which is called the ellipsis. That also allows you to synchronize the entries you have made and also select all the cases that are on the screen. Then if you go to the left right button, you can also see the three horizontal lines there again, which also allows you to select and perform certain functions. So we'll later look at what all these do. So for a start, if you want to add a case, you just open the app and look at your right upper corner and locate the plus sign, which is called the add case button. So when you click on the plus, as I have done, the system will open and give you access to the various questions that are demanded for the case creation. So we'll quickly look at what is required. The first is to, as Dr. Alayi mentioned in his opening remarks, in the coming days, the system will be updated so that it will meet the specific diseases that are required and be aligned to the case investigation form. So in the weeks to come, you may not see some of the questions that appear here. The questions that will appear will be specific to the particular disease that you'll be doing the entries for. So the transmission classification is a mandatory field. What you need to know is that all the questions that has the red star or the asterisk should be answered before you can move to the next page. So for transmission classification, you are expected to choose unknown. We have the known community transmission and the unknown. In people that come to the facility, we principally do not know how they were transmitted. So we advise that for this question, we'll choose unknown. Then the disease that you are doing the entry for, we have the list of the priority disease that has been entered on the system. So your duty is to choose from the list. So assuming we're doing this entry for, let's choose cholera, which is the outbreak ongoing in some districts. So assuming we're going to do an entry for cholera, what we'll do is to select cholera from the list. Then our account will auto select the responsible region, the responsible district. Then our duty is to choose the sub-district that our facility is located. So this is an account for Shama. So my facility, for instance, is located in Shama sub-district. Then we'll go to the place of stay, which is asking where we are doing the diagnosis. So this question is quite tricky, and some of us misunderstand it as the address of the patient, but that is not what it's asking. So it's asking, in other words, where are we diagnosing? Where are we diagnosing the case? As I mentioned, it will be one of the questions that will be changed so that it will suit the specific case investigation form question. But at the moment, we expect data officers or surveillance officers to choose facility, as it is the case in most of the conditions or cases that come to the health facility. So say you choose facility, then the facility category, you are expected to choose medical facility, then facility type at hospital. We have other type of facility there. It will be one of the fields that will also be changed. Then we come to the facility name. So if you look at your sub-district, the list of the facilities there have already been provided. So you choose from the list. In the event that you do not find your facility there, then you select other, and then it will give you option to type. So I'm reporting for maybe Shama Health Center. Then we come to the EPID number. So SORMAS has been configured in a way that auto generates the EPID number. So you are encouraged to leave the EPID number blank. As you save, SORMAS will assign the EPID number based on the last entry that was made. So it will sequentially continue from there. The date of report is asking when the patient came to the facility, which is in most instances are the dates that the entry is to be made. However, in the event that the entry is not being made on that same day, we expect that you choose the date that the patient reported. So we assume that the patient came to the facility today. And let me emphasize that SORMAS is supposed to be the case investigation form. So the expectation is you would use this tool to interview the patient. So going to the consulting room when the suspected cholera case has been referred, we expect that you would use the SORMAS app or software to interview the patient. We don't want to encourage the situation whereby you fill the paper-based case investigation form and now come back to fill it. So you use it live as you talk or interview the patient. I hope that point is well made. Then we come to the symptom onset, which is the date the patient started experiencing symptom. So let's say it started 2 days ago on the 22nd. Then you ask the patient's first name. So their last name. As you can see, these are mandatory fields. I want to emphasize again, all the questions that has the red star or the asterisk are questions that you need to answer. If you don't fill them, you will not be able to proceed. To demonstrate that, I will intentionally leave the last name so that we can all see. Then you ask of the date of birth. If you do not have the actual date of birth, kindly leave this field unfilled. Do not enter any data here. Let's say, for instance, you mistakenly chose the year of date of birth, but you later found out that the patient do not know their date of birth, but you mistakenly chose 1990 as I have done. How do you clear it? You just go back, then you scroll up of the dates, then you see the clear option, and that will enable you to clear the entry that you have made. I see some colleagues struggle with this, and as they select the year of date of birth, they are forced to now cook figure 4 the date of birth, even though the patient said they do not know their date of birth. So any selection that you make, you can always clear by going to the first selection at the top. So the sex, obed is a male. Then the present condition of the person has option alive, dead, buried. So the patient is still alive. So let's say you've made all this entry, you cross-check to be sure that is what you were looking for. To the top right corner, you see the check sign. Or in primary school, when you answer the question correct, the teacher gives you that sign you see there, you click on it. So this was to demonstrate that you do not enter a mandatory field, you cannot proceed to the next stage. So the system has given us an alert which says that please enter a valid value for last name. To learn more about the error on a specific field and how to solve it, click on the error indicator next to there. So it's because I did not enter this mandatory field. The system has prompted me that I need to enter the surname of Obed. So now I'll go back, clear the error message, and then I'll enter the surname. Then now try to resave it. Then you can see that it has successfully saved and allowed me to proceed to the next stage of the case creation. I hope that part was clear for all of us. So this is just the case information, which is part of the patient demographic information. So you would now proceed to the PID number. As I've said, the PID number is generated at the district level. If you are doing this entry for facility, you do not generate a PID number. So the era of where we needed to call the district to know what was the last AFP case so that they will give us the number. If we enter it using SORMAS, SORMAS will automatically assign the sequential number based on the last entry. So if the last entry by the district account was 004, this new entry will automatically change to 005 once you complete the entry. So you are not required to create the PID number. In your quest to manually enter the PID number, you may end up duplicating the PID numbers because somebody might have used it to create a case in the system and you're also repeating it. For external and internal token, it's not a field that you are required to fill. It is to be used by the IT team for interoperability purposes. Case classification, you need to classify the case. So is it a suspected case, probable, or confirmed? At this stage, it's a suspected case. Then the date of report has been shown again in case you made a mistake, the classification, the disease, and all of that. It is asking of the disease variant, which will be removed because at this stage, we do not know. The reinfection question will also be looked at and be removed in the next update. So for here, it's asking whether there is an reinfection case. So it is most likely to be unknown, or if the patient's record shows no, you can also choose no. Then the case ID, investigation status, all are to be, they are just read only fields. So these are information that has already been entered and the system is just showing it to you to verify the information that you entered. So after that, you go to the right upper corner and then you would save. From here, we go to the patient, the person information. So these are additional demographic information also about the case. As I said earlier, if you do not know the date of birth, you skip, and then the system gives you the chance to enter the age. So we did not know Obed's date of birth, for instance. So Obed is 35 years. If Obed was a neonate, then maybe he was just born 7 days ago, the unit of measurement, you now change from years to days. If Obed was less than 1 year, possibly 11 months, then you change from years to months. So let's take notice of the unit of the age measurement. But in our case, this patient is 35 years, so you select the years, then his sex, all of those information are there. Now, if you now have to enter the home address of the patient. So the region where the patient is living, Shama, is in Western region. The district, the sub-district of the case. Then you can come to the community, which here is the city. So he's in Shama North. That's the northern part of the town. That's where the patient is staying. And he's at the Commodore Street. The house number is SH221/4. Then there are additional information, whether the area is urban or not. If you want to add an additional information, maybe behind the Chief Palace. Whether urban or rural, the area is urban, and the sub-district contact person, maybe the volunteer's name, you may enter all of that. Let me add that, as Dr. Atta and Dr. Lai mentioned in their remarks, the system will be updated and some of these questions will not appear like the way they are. But as we use them, we are trying to demonstrate how to configure and realign them to be close to the specific case investigation form. So when it's updated, you would see that the question about cholera in terms of the home address will be the name of the community, the house number, and the GPS coordinate will just be requested to enter. So if you were in the patient house, then you can just pick the current GPS coordinates by clicking on the pick current GPS coordinates. So where we are currently in the office is the latitude and the longitude has been picked. So the accuracy is very low. For it to be close to the actual location, it should be about less than 5 meters. So always ensure that the accuracy is less than 5 meters. Otherwise, what you are picking is actually not in close proximity to where you are actually standing. Because of time, we will not spend my time on the making sure this is 5 meters. So I will click on the OK and then save. Then we'll come to the education level of the patient, whether no education. So this patient is tertiary level. His occupation, we have the list here. You look through and select the one that is applicable. If you do not find the actual occupation in here, you may choose other, and then you can now type the details. So surveillance officer. So in some instances, the patients are too young, like neonate, they do not have names yet assigned, where in our practice, we call them baby grace by adding the mother's name to it. So for neonate and young children or newborns or under 5, you may want to add the mother's name as a reference so that we can actually use them as contact person for follow-up. You may now add the person's contact details, and this is where you can actually add the phone numbers of the patient. So we have the phone number, the mobile, then the contact information. You can now enter the phone number here. Then you can save. Then if there are general comments you want to add about the case, so after you've done that, you can go through to be sure the information you've entered is correct. Then we go to the right upper corner and then now click on the save button. The next tab is the hospitalization information, which is asking about admission status of the patient. So the first question here is, was patient admitted at the facility as inpatient? That is to distinguish the case of OPD from those that are inpatient. So let's say this case was admitted, so we'll choose yes. Then now you come and fill the date of admission. So the patient was admitted today. The date of discharge or travel, the patient transfer, the patient is still on admission. Then the system is asking, is the patient on ICU? No. Did the patient leave against medical advice? No. Then patient condition on admission, the patient is in moderate state based on the medical records that you review. Was the patient isolated? Yes, because in most cases, cholera will be isolated. Then you look for the date the patient was isolated, which was today. These are information that you need to pick from the patient's record. Because of time, I'm just reading them, and these are just not a real occurrence, but the expectation is that on the field, you would consult the nurses, the doctor, and then pick the patient's record to answer these questions. You are not supposed to assume, but rather you do detailed records review to obtain this information and use them to answer the hospitalization questions. So the reasons for hospitalization is the patient reported a disease, is because the patient was supposed to be isolated, and then other reasons. So in most cases, the patient is being isolated because of the reported disease. So was the patient hospitalized, or did he or she visit a health clinic previously for this illness? This is an information that can be obtained from the patient. So based on the response and the records review that you obtain, then you can answer. Let's assume this patient was no. So after that, you review the entries that you have made. The patient condition on admission is mild. That has been answered now. Now you can go back and then save. So the next is the symptom information. So the system is asking the body temperature. As I have said, I want to repeat for those who just joined. You can see questions that are here that may not be applicable to a cholera case. And the reason is that this is a generic that has been assigned to all the diseases. In the coming days, would update the system. And if you open cholera case, you would only find symptoms that are applicable for cholera and are found on the cholera case investigation form. So you may see questions that may not be relevant as far as cholera is concerned, but in the interim, we are still expected to use SORMAS to do the entry. So I'm going to guide us on how we could answer the questions in relative to cholera. So what was the patient's body temperature? You review the records at the time the patient reported. Let's assume it was 37.8. Then the source of the body temperature is asking whether it was taken from the armpit, oral, rectal, and what was actually used for it isn't the non-contact infrared thermometer, which is now basically used in most of the facilities now. So I'll choose that one. So the signs and symptoms. It says, please select an answer for all symptoms, indicating if they occur during the illness, between symptom onset and case detection. So the easiest way to answer this is, first of all, because the symptoms are many, from muscle pain, anorexia, up to other clinical symptoms, we advise that you may choose clear all, which will deselect all the options you've chosen by mistake. Then you go to the right corner, which says set cleared to no. So when I click on set cleared to no, you see that the system has automatically selected no for all the symptoms and the complications that have been asked. If you choose set cleared to unknown, the system will choose unknown as the answers to all the questions here. So let's choose set cleared to no in order to save time in answering the questions, because we know some of the questions being asked here may not be applicable to a typical cholera presentation. So we'll choose set cleared to no, then look through the ones that are on the cholera case investigation form. So cholera, you may be interested in checking if there was blood in stool. So the patient said no. Whether there was dehydration, since it was a mild condition, it's very likely this patient wasn't dehydrated. Was there diarrhea, which is typical of cholera? So you change now the no that has been selected by the system to yes. Was the patient complaining of general weakness or fatigue, which could be yes in our case? Was there fever? The patient said no. But if there was fever, you may change the answer to yes. Was there nausea? Yes. Refusal to feed or drink? The patient said no, so we may leave it. Was there vomiting? Let's say yes. Then other clinical signs. Now we go to the complications. Were there altered level of consciousness? No. Confused, disoriented, convulsion, sepsis, and what have you. So if all these apply, you now change the responses from no to yes. Then we come to the date of symptom onset, which was entered earlier. The system is prompting you to review. Is that the actual date of symptom onset? Then if you entered wrongly, you may have the option to now change, but this is the correct symptom onset. Now we come to the first symptom among the ones that we've selected as yes. If during the records review, this information was obtained from the patient and it was confirmed that the patient actually reported that fever was the first symptom that came or diarrhea, then you may choose the specific one. So when you finish, as I've always said, you review the answers you've chosen to be sure it corresponds to the answers the patient provided, then you save. Then as epidemiologists or surveillance officers, we know that epidemiological information is very important in the surveillance work that we are doing. So this exposure information has to also to be answered. So the first one that is currently on the system is asking if the patient is residing or working in an area with high risk of transmission of the disease, such as close residential and camp-like settings. So based on this one, let's say we choose yes. The patient reported that they work in a place that put them at high risk of the disease because of their work schedule. Was the patient residing or traveling to countries or territories experiencing outbreaks of local transmission? Let's say it's no. Then please document all relevant direct exposures. So the exposure details can now be filled in the cholera case investigation form. The epidemiological information that normally ask is the food history, the water history, and what have you. As I have said, all these will be revised soon so that the specific epidemiological information that will be required will be the one that is actually on the cholera case investigation form. At the moment, these do not actually fit what is actually expected of cholera. So if you click on the exposure details, you can now come here and then describe what the patient reported. So start of the exposure, the end, the description, type of activity could then be filled for that. So you save. Then, as I said, we're also supposed to look at the sample management. So SORMAS has been configured in a way that restricts access at all levels. If you have a district account, you can only have access to cases or entries that have been made in your district only. If you have a facility account, you can only see cases that have been entered for your facility only. If you have a regional account, you have some elevated level of privilege to see all entries in your district, which means all the district entries could be fixed by you. And at the national level, you have the capacity to see all entries made for the country. Now, for the lab, which are specifically our reference labs, they have access to samples or cases that have been referred to them. So in some instances, the district person will say, oh, I've done the entries, but the lab is saying they can't see it. That is because the lab do not have access to see the entries unless the sample has been referred to them. So colleagues, I want to raise the point that if you do the case entry, but you do the sample details, the lab will not have access to the entries that you have made. If I ended here, or if I end the entry here and bring the sample to, let's say, the National Public Health and Reference Lab, they will call you and say, oh, but I can't see the entries you've made. The reason is because I forgot to fill the case sample details. So please, at all points in time, let's remember to fill the case sample detail and also choose the appropriate lab so that the entries could be accessed by the appropriate reference or zonal laboratory. So to add the case sample, just like the case, the add case button, you click on the plus sign, then the new sample menu will open for you to enter the details. So you can see the read-only information. The sample ID is there. To be sure you are filling for the case, this is the corresponding person is obedophory. The disease is cholera. So now the specific questions. Dates sample was collected. We collected the sample this morning, so we'll choose 24th. The time the sample was collected. If available, you would enter. So the clock will open for you, and you have the minutes and then the hour hand. So the first thing you see is the hour hand, which is on 12 midnight. So we collected it this morning. So it's in the GMT. So you hold and drag it to the back, since the back ones are the morning time. So we collected it around 7 o'clock this morning. Then the minute hand will just come. Let's say we took it at 7:15. So you can drag on any of the times here. As you drag, it keeps moving. So we collected it at 7:15. Assuming we collected it at yesterday, 8 o'clock, that would have been 20 hours. So instead of dragging behind, we'll go and push it back into the inside, and then we can choose it back to the 0 button, and 8 o'clock will change. But as I said, we took it 7:15 this morning, so we'll set it as such. Okay. Then the purpose is asking, why was the sample collected? This looks absurd, but you are still required to enter it. So why are you collecting the sample? It's for external lab testing. So if your hospital also has the capacity to test, then you may choose the internal or in-house testing. Some of the regional and the teaching hospital labs may have the lab capacity to test some of these samples. So assuming this case was being entered at Ifya Kwanta Regional Hospital, which has a lab that can do cholera tests by, you could have just chosen the internal or in-house testing. However, in most of the priority disease, the testing is done by the national or the zonal reference lab. So we want to assume Shama does not have the capacity, so they are referring the sample to the National Public Health and Reference Lab at Kolebu. So we choose external lab testing. Then we come and choose the type of sample. So cholera is stool sample or rectal swab. So depending on which one you took, you can look through the list. So we have the stool, which is the third option here. Then the reason for sampling or testing. So the options we have here is presence of symptoms exposed to an outbreak area, screening, professional reasons, and what have you. In most cases, these are early cases that are coming. So we are testing because the person has become symptomatic. So presence of symptoms. However, if depending on the circumstance, the others are applicable, then you may choose. But for routine surveillance, we are testing because of the symptomatic nature of the patient. Then we come to the scan field sample ID, which gives us the opportunity to scan the barcode, which we will affix on the sample container or the sample transportation form. So when you scan field ID, the barcode open for you to scan. At the moment, we do not have a barcode available. We'll get it and then demonstrate. So as you click on it, then you use that option to scan the barcode, which will pick the barcode ID and automatically put it in the field sample ID. We do not encourage you to manually write the field sample ID here because you may make mistake. And when the sample come and the field sample ID is not the same as the one that has been fixed on the barcode, when the lab receives, they will not be able to locate the case. The importance of the barcoding system is to allow the lab to receive the sample in a swift manner. In other words, reduce the turnaround time. Imagine Kolebu Public Health and Reference Lab receiving all samples of measles, all samples of yellow fever, and in a week they receive over hundreds of samples. And the officer is supposed to manually receive them one by one. That takes a lot of time. So the IT team has come up with an innovative idea by printing the barcode, which we are expected to use. So when you scan the barcode field and the sample comes here, they equally scan, and that helps them to locate the case fast in the SORMAS app. If you manually write the barcode ID and you make mistake, you distract that system, and that makes the work difficult for the lab and all of us at the national level. So colleagues, always scan the barcode so that the ID will be the same as the one that has been printed on it. So sample is for retest, yes or no. In most cases, these are fresh samples, so it will be no. Then the name of the lab where the sample is going, you click on the drop down. Cholera, Shama is bringing it to maybe secondary public health and reference lab, which is a zonal reference lab. It could be selected, but let's say they want to bring it to National Public Health and Reference Lab. So the labs have been listed in alphabetical order. So N, which is the National Public Health and Reference Lab, is chosen. If you have an additional comment, you may write here. However, you can leave it blank. Now, request pathogen test to be performed. So you click yes, then you look through the list here. For cholera, we expect the lab to do culture by growing the organism, so you select. However, for other diseases, you may want to do the PCR and what have you, but for cholera testing, the lab basically is going to culture the pathogen. Then other tests, if you want to, then if you want to do additional tests, in most cases is no. Then another important field, which is the send or the dispatch details. So the date sample was sent. When did you send it? You know, in our reporting purposes, samples are supposed to be sent immediately. For cholera, if it's a fresh stool, you are supposed to send it immediately fresh like that. However, if it would not be sent immediately, you have to store it in the carrier medium and then use the reverse cold chain system and transport to the lab appropriately. So we'll send it today. Then the dispatch details, if you want to type, so maybe it was sent via EMS. Then you look through the information to be sure you have filled them correctly. Then now you can come and save. So the moment it is saved, you can see that the case sample detail has been completed for the patient. So I will pause here for us to and give the opportunity to Dr. Atta to come in. I think there are a lot of questions that have been put in the chat. Since he's our boss, he will help us address them appropriately. Thank you, sir.
Thank you, Obed. Thank you very much. And I think that was a good take through how the tablet interface looks like. I think some of the questions that came, we have attempted to answer them. So I think most of the answers have been provided in the chat. If there are any more questions, we can put them there now, and then we would be looking at that. So a few things to emphasize. A lot of times, I think some of the complaints have been related to, there are many fields here that are not on the case form and the rest. The truth is that paper is not, you can't put all the information there. And for all of us in public health, you will say that every information there is quite relevant if you were going to follow up on a case. Just that you can't put it all on a paper. It will just be impossible to even carry that paper around. The electronic systems allow that. But as we have been mentioning, the effort now is to align the case form the way it is as much as possible to what is on SORMAS, and then maybe gradually include additional fields as may be relevant. So very soon, the new version that may come out, you will see that it's more aligned to the paper form that you are used to, maybe with a few additions that are relevant because we are using an electronic system. So that is something to take note of. As much as possible, we want to ensure that we have the information that we need to put in the system. And as we said, the key is to carry our tablets and start the case entry from there. And then, of course, as more information is available, we update it. I see that the time is quite gone. As we said, this is going to be a clinic. So we will be doing this very often so that we can always take one issue and address it thoroughly. If we try to address everything, it may be a bit much, and we may not be able to capture everything. So today the plan was to do a whole lot of things, but we are looking at the time and maybe we will not do some of the things that we said we would want to do today. We will just want to look at the questions that have come in, and then we try to look into that. For now, I see a few questions here. Someone is asking about scanning the barcode. You cannot scan the barcode using the computer. That's why we are saying that data entry as much as possible should be with a mobile device. If you don't have the mobile device, that is where the challenge is. If you are using the laptop, then you have to type in the details on the barcode into the interface. Sometimes the challenge is that there may be errors. So we will actually have a session, maybe in the next session. I think there's a lot of interest on barcode. So the very next session may just be to also take details, how we do the barcode, and then everybody can be abreast with that. So that is something that I can promise. Look at that. If somebody entered data into SORMAS wrongly, if you're doing this on your tablet, and depending on your level of access, it may be impossible to correct this when you do that. But the surveillance officer account, the district officer can and quickly change that. If a case shouldn't have been in SORMAS and has been entered through the same communication channels, we can discuss at the national level and take a decision whether to delete the case or not. The surveillance officer, disease control, health information officer, we know that entering the cases, looking at the surveillance data, using it for reports, the surveillance officers, disease control officers all do that. May not be the one entering the case details and all that, but the data, they are part of it. So the access given to the district works for all these officers to play their roles as they have been. So let's ask ourselves, when we had the paper in front of us, what did everyone do? We are only saying that the same structures that we have, we are using the electronic means to do them. So SORMAS is not changing the rules that everyone does. If the health information officer used to take the paper form, puts information together, the system is doing that. So that officer also needs to use that same access for the district and be able to do their work. Where do you get the barcode? We've mentioned that barcodes have been given to our regions. They've been given through the regions to the district officers. And so they are supposed to make it available to us. Any tablet that is being used at the district level should be able to have the SORMAS app installed. We are running an integrated system. So no matter what the program that brought the tablet, we expect to be able to use it to support the work being done at the district. So if surveillance department brings tablets, we want to put SORMAS on that. And if there are any other things that we use tablets for in the district, of course, that tablet should be able to support that work. And if it's from malaria, if it's from TB, it is all part of the work that we are doing. So the apps are there, and we should be able to put these apps on them, on the tablets, whichever tablets we have, and make them work. So yes, as we said, the CPD will come. The year has started. The registration will be submitted to our councils, and then when approval comes, our details would also be given. Now, results on SORMAS. So put in your sample details, make sure the case is there, select the correct lab. As long as the lab has worked on it, they will give the feedback. Remember that there are also other challenges beyond documenting the case. And so sometimes that is the challenge. If a client does not know their date of birth, how were we doing this on the paper? We may estimate the age and all that. We won't say that we want to leave it blank. So these are ways that we do that. So please, EPID number is not the sample, the field sample ID. EPID number is not the field sample ID. So we see a lot of people populating that field with the EPID number, and that is wrong. We have the barcodes. If we don't have them, please let's talk to our district officers. Let's talk to the regional surveillance officers to make them available. Yes, and as answered, one account is used by multiple users. So it's that the account is for the lab or for the district. And so all officers that have to do work on SORMAS use that account. So here we are talking about SORMAS. So we don't want to talk about other challenges. We are not in a position to address them here. But these are valid concerns, and then we would address them appropriately. We will also put out our contact, the email for the office, so that you can also reach out to us. And then, as we said, we'll be running these clinics so that we can always have this information for our use. Update the case-based forms to capture information required when we want to move away from the case-based forms. So we will not be spending resources to update the case form. SORMAS will be updated appropriately, and then we can always move on to use the electronic system. That is the mindset that we want to adopt. We are trying to move away from using the paper because these systems make our work easy. Thank you all very much. When we have the results from the lab, yes, there are some times when there are challenges with the changing. We are looking at that, working with the lab so that we can have that quickly change when the results are done. Let me clarify something about the lab selection. So remember that per the IDSR guidelines, we have standard labs that certain priority diseases are supposed to go to. It is important that we are familiar with this and make sure we do that. When my facility has the capacity to do an internal test, it is taken as a what? A preliminary test. The confirmatory test that will be accepted to classify the case at the national level has to be from that standard lab as our IDSR structure provides for. So if you are able to do an internal test in the lab, by all means create that on the system, choose internal, and you have to go back and put the results there. But also then select the appropriate lab that also has to work on that same sample and give us a result that can nationally be accepted and documented. So let's understand that structure and make sure we can work with it. If you have a tablet that is not able to run SORMAS, it may be the capacity of that tablet. And so it is important to then look at how we get more tablets into the system. And the department has been working very hard to get us more tablets. Our regional and district officers can attest to this. And as mentioned, any other tablets that we have in the system, from the facility for limbs, all those things, we want to make the effort to do that. Please do the entries on SORMAS before you are moving the sample. And that's what we used to do. You fill the case-based form before you attempt to move the sample. So it's important to make sure that we are doing things the same way we used to do on paper, and not to say that the sample has gone, it gets to the lab before we are getting into a system to attempt to enter the case. So it's very important that we understand these things. Right, so I see that there are a lot of questions, and as I said, the presentation has been recorded. It's available on YouTube. It will be updated on YouTube, and we can all be able to update ourselves, watch it again, and understand the context of what we have discussed today. We've mentioned how the sample, the case deletion goes through. Work through your district surveillance officer, your regional surveillance officer, and let us see how we can support this to be done. We don't want to bypass our structures. Let's work through our district surveillance officers, our regional surveillance officers. They already know how they work with the regional surveillance, the national department to get some of this working through. So please, at this point, I'll encourage our IT team. People are asking for emails to contact the team here, and maybe a number. Also, the recent or the current URL for SORMAS to configure the tablets. So let us look at that. As mentioned, this session is to help us to understand the skills we need to work on the system. There are a lot of other challenges that go beyond our skill, but for the scope of this session, we want to be focused on picking up the skills, and then we will be able to work on the SORMAS system. So maybe looking at the time, we may want to begin wrapping up, and maybe take the time to look at a few things we have discussed here. So when we at our performance on the poll, I think we can see that majority of us answer that they use SORMAS to work. So that is a very good thing to note. And also 35% only 26% have ever been in a formal training, and about 9% of us actually taught ourselves to use the system, which is very, very, very commendable. And about 31% have never been trained. We hope that these sessions will be very useful to provide this training that we all need so that we can use the system appropriately. And yes, of course, the current version of SORMAS is 1.74.7 as we put into the chat. So that is it. And if we check a system, I saw that Janet earlier on actually gave a quick steps of how to check for your version. And that was very, Janet, thank you very much for that. So it's all part of knowing how to use the system. Maybe in our next sessions, we will take us through how we get into the system to configure our apps and all that. And as mentioned, we want to use the tablet app for case entry. And yes, majority of us actually do that. We want to encourage that. Encourage web version for case entry. It requires internet, a good internet connection. And so sometimes that may be one of the reasons why we may delay entry. But of course, we can also see that very few of us are using the web version for data management and supervision. And in our recurrent sessions, we will attempt to show how we can use the web for data management. And access to the web version is open for surveillance officers and above, because we expect that they should get into the system and be able to look at the data people have put there and how it looks. So about a quarter of those of us here who answered the poll have, we don't do any of this or we don't use SORMAS. We are hoping that we can reduce that number to the barest minimum. So thank you all very much for responding to the poll. We will also be sending a link after here, and it will also be a survey that you can register your details, as well as also give us some feedback about some of the things that you wish for us to discuss in these sessions going forward. So I think I see a few hands up. Obed, did you want to address something? Yeah.
Yes, boss.
Please go ahead.
Okay. Thank you, Doc. So some people are also asking how they can delete. So to delete it, you have to notify your district officer, the region, then the information will be brought to national level. Then the national users can on the information that has been provided. The users at the region and the district facility do not have the access or the authority to delete entries. This is for security checks. Otherwise, you just go to the system, create anything, and then you delete. However, you can edit the entries. I think the next clinic will look at how to edit the entries that you have made. Assuming you entered wrong date of birth and you want to edit the date of onset, you can edit. But to delete is at the national level. Some people are also saying, for instance, cholera. The facility can do RDT, which is positive, but becomes probable, and there's the need to do culture. So in that instance, you need to do 2 sample entries. So yes, for some conditions, you would have to do double entries for the sample creation. For instance, meningitis also, some do the latest vaccination before they do the culture. So when you are doing multiple tests, it means that there's some. And for those of you who do not have the latest SORMAS version, your entries may not synchronize. What it means is that after this meeting, go to your Google Play Store and then update your SORMAS. Like the same way you have been updating your WhatsApp, your app. If you go to your settings and look for the app that have been installed, you will see that SORMAS will be there. That will enable you to do the update. Otherwise, you can call us after the meeting. New put our number out, and then we can support you on how to update. But the system can also prompt you to update. And when you see that prompt, you need to update. If you don't update and you are still using the older versions, you will struggle to synchronize. You do the entries, they will call you, I've done the entries, but the lab say they can't see it because you are using an outdated version. Thank you, Doc.
Okay, thank you very much, Obed. I can see a lot of very interesting questions. Okay, so I think Ebenezer Oscar has a few questions, and I think Sevedo's hand was up earlier. So please, Ebenezer, you can unmute and please go ahead and ask your question.
Good morning, Doc. Please, I'm speaking from a local project on the project of the we work on the weather. I think within last year, in the middle of last year, we had training on event-based surveillance, which were taught us to be part of SORMAS Clinic and the reporting people. But on this training, we only have presentation on the cases, but on the event based we were not matter of time. I wanted to know if there's going to be a third section because we at the point of review. That's also thank you.
Okay, thank you very much, Ebenezer. So, as mentioned, anything to cover, but we cannot keep the audience for expecting that people would also be doing their work. So today, as we have said, we have introduced ourselves using the app, and we have to even go deeper into the sample creation, the use of outputs, signal registration, and then even what we do on the web interface and all that. So this is very rooted, and as we'll be sending out a link where we can always put in these things that we all want to be taken through, and then it will be now based on what we as staff on the ground want the team to take us through, and we'll be doing this as frequently as possible, maybe at the beginning a bit more frequently, and as we cover the key things that people are interested in, we can space out the sessions a bit more, because I think the interest, as we are seeing, is very high, and we want to encourage this. So thank you very much for your question. Oscar, please go ahead.
Yeah, thank you very much, Doug. My question has to do whether it's a question or proposal. For instance, the portion where we have a type of locality, the fellow have to choose rural area or urban area. Can we put a dash there to give specific description of that rural or urban area? Because this cholera has taught us few lessons that when it started from my district, it was starting from the coastal communities and then along the coastal belt. If such information is already there, I think that it will help decision making. So apart from we choosing whether it's urban area or rural areas, I think if we can have some few portion to describe the area, it will be very helpful. Over.
Thank you very much, Oscar. So for now, the easiest way to do this is to use the comments. I think there are free comments features, and we can always add on this information. When reviewing the information on SORMAS, we are able to look at some of these things. So thank you very much for that suggestion. We'll take maybe, okay, a lot of hands. So Stephen, and then followed by Jumel. Hello, Stephen.
All right.
Yes.
Thank you very much, Doc. And thank you too for the presentations. Please, I would like to know, since we've mentioned that there's going to be an update where some of the features are going to be taken out and some be added, is it advisable that maybe today, tomorrow, and a certain facility take a sample or suspect a case, they should do the entries in it, or because of the update, they should wait till the update is done before they do the entries for the suspicion of maybe after the update, the information might be lost? Thank you very much.
No, nothing will be lost, Stephen. So nothing will be lost. Definition of surveillance, ongoing. So we are only telling you how, because it's an electronic system, we are in a position to always improve the system. So the understanding is not that what is there is not useful, so don't use it. We really don't want to go away with that understanding at all. We are using SORMAS the way it is now. It is useful, it does the job. We are only saying that because it's an electronic system, we are always in a position to improve it as we go. Changing paper form is not as easy, and it's also not cost efficient. You have to now print all over again. So let's come with that understanding. It's not to say that what is there should not be used. Wait till later. Please, we don't want to even hear that. Thank you very much. Jobel.
All right. It's still morning and good morning, everyone.
Good afternoon. Please continue.
Good afternoon. Okay. This is Mr. Mohamed Akolo, Municipal Disease Control Officer, East Mamprusi District. My question is still on the deletion of wrong entries. Please, can something be done about this so that the right will be brought down to the regional level, so that after making a wrong entry, immediately you should be able to communicate to the regional boss to do the deletion? I don't understand why that right should only be limited to national. It makes it difficult. Last year like this, we had such wrong entries where the district did and then the facility also did, but we couldn't do that correction till the year ended. So let's look at it, because just like DIMS is open for up to 2 months. So if I do a wrong entry, maybe I want to enter 3 and I did 30, I'm able to go and do the correction. But for SORMAS, that is not the case. Sometimes somebody wants to enter contact for a particular case, but he goes to enter it as new cases. So, and the deletion becomes a problem. Sometimes you contact region will say they will contact national. It stays on till the year ends. And that way it doesn't make data accuracy. And the next question is the test results being put on SORMAS. I think nationals should look at it so that there will be a pop-up on the dashboard to show that your test results have been kept at a distance, so you can quickly go and then you look at it and you would know which sample results has been brought and is positive or negative. But in this case, it's not like that. Sometimes, unless you log in, go case by case, and before you would see the test results for that case, sometimes we need to get these results early, or once we get the results, action need to be taken. But once that is not known immediately, sometimes you'll be there, region will see it and now notify you that this particular case, the results is kept in SORMAS and is positive or negative, so do this and all that. Thank you very much for the opportunity.
Thank you very much. I think the points that you raise are very important. So the issue of this data access and control and all that, I think it's being debated. These decisions, as you rightly said, at the national level, and it's because of some of the data protection issues. But I think the discussion can continue so that we can look at how we make this happen. With the alert for especially results, it has been discussed extensively. And for now, some of the changes, I think some of the apps, if the notifications are enabled, you get it. But on the web, for now, the best way is to use the dashboard, because now when you do the dashboard and you are doing a day-to-day comparison, down there, when you select the disease, you are able to see how many new test results have been put in. That is maybe for now the best way. But yes, this issue that you bring up has been discussed, and it's something that we are seriously considering, how we maybe include a notification panel on the dashboard to even help you, the municipal or district officer, to see even what your facilities under you are doing. So thank you very much for these wonderful suggestions. Salvador, is your hand still up? I can't see you anymore. Just a minute, you were on, I can't see you anymore. If you can show your hand again so that I can allow you to. unless your question has been answered. So, okay, good. You are back because I think your hand came up much earlier. Please go ahead and ask your question.
Okay, thank you very much. So my colleague has asked my other question already, which has to do with the deletion of multiple entries at our level, which you have answered. So that is it. The concern is we should be able to handle that locally without keeping it long in the system. The second one, which I just realized you also answered privately, there is the need for us to align the flow of entry of data from the case to the sample so that nobody misses that step where they enter case information and the sample information has not been entered. So just as we fill the form, as the person is making the entries from case to sample, it has to flow so that nobody misses it. So that is the suggestion in there for our IT team to look at for us. Thank you.
Yes, thank you. It's good. I think as mentioned before, when you get to the end of the case creation, yes, as you said, you have to remember to put the sample information. Now, it would jump you to that and it would want you to ensure that you put in the sample information. So that feedback is already worked on and we should see that very soon. Thank you very much for your inputs. Eva, yes, Eva in Cancer, please go ahead. Hello, Eva, please go ahead.
You're on mute.
Okay, Ambrose.
Yeah, okay. Thank you very much for the opportunity. This is Ambrose, DBR District, Upper West. Please, my concern has to do with the conflicting entries when capturing a form that already exists for a particular name, which has another case, probably whether it's YF, and then I'm entering measles for the name of the particular case. However, with the conflicting details that is usually displayed, it could be more convenient if instead of only the conflicting details, if the type of case is also displayed for which you are entering. Maybe the previous one is conflicting with whether it was measles captured or meningitis, and the current one captured whether it's YF or any other condition, so that that decision can be taken quickly to select the appropriate field. Otherwise, there are times you abandon entries and then you have difficulties and you have to go start and then enter for the case again. Or you accept entries that probably already exist, which you think is different. And
okay, thank you very much. Okay, continue.
The next concern has to do with the facility type selection. I think usually it's when you go to the medical facility as the health facility. When you go to medical facility, and then you go to hospitals, then there you'll see health centers and then chip zones under them. But this, if it could be looked at again to categorize them based on where they appropriately should fall under, whether like that category of chips and the health centers, so that was selected as such before we see the corresponding facilities to select. I think that could also. Thank you very much.
Thank you very much, Ambrose. So your question shows that you are an advanced user of the system. Because what you are describing, I'm sure a lot of people will say that they are not even familiar with that. So once you put a case in SORMAS, SORMAS records that person as an individual, a person. And so I can come in today with yellow fever, I can come in later with cholera, I can come in later with COVID, but I'm one person. So this is some of the things that Ambrose is describing. I think that it's something that has been looked at. We should have a session on how you manage those scenarios. And so I think as the clinic sessions go on and we are all coming to the advanced circumstances, some of these things will be covered and explained in details. The question you asked about the medical facility, and I think we wanted to emphasize this when we're going through. SORMAS is an open source software. Different countries with different systems will be using it. So what we do is to configure it to match our system, and that's why you can't get it on Play Store. You have to get it through the Ghana Health Service system, the regional district structures. So for us, we just want to understand that the way to see our facilities is to pick medical, pick hospital, and then you can see your facilities. Because the value is not the classification, but where the case is coming from. So when we are looking at the data, we are interested in the chips, the health center, and all that. So the way to do it now, the way the mother system has been set up so that it can work with us, don't choose anything else. Go for medical facility, go for hospitals. You will see the facilities that you should see, and then you pick the right name of the facility. The name of the facility for us, when we have that data, helps the region, the district, the national level to do the classification appropriately. Anything else is asking people to choose too many things, which then becomes a bit confusing. So let's take this one as it is, understand how that part should be selected so that we see the appropriate facilities and pick on them. If you choose any other thing, you won't see your facilities. But once you choose the two in sequence, as I've mentioned, you would see your facilities with the appropriate designations as a CHIPS, as a health center, as a private facility, and then you can pick on it. So let's understand that, and then we can make it work. So we'll take the last maybe 4 questions, and then we will leave it here. As we said, we'll have another session. We'll invite you, and then we can address even more questions as we go. So Justine, and then followed by Bruno.
Okay, thank you very much, Doc. Please, like you said, my name is Justin from Upper West. Please, I posted my question earlier in the comment section, but it has not been answered. I want to find out how the labs, the reference lab, receive sample and then they input the results after testing. I'm asking this because the Upper West Regional Hospital lab serves as the reference lab for meningitis testing in our region, but they've not been entering the results after testing. And the reason is that they've not been trained. They don't know how to do it. So if you can highlight on that, or if there can be a separate session for them to be trained on that. Thank you.
Okay, thank you very much. So in Upper West, we are having the rich assist all that. When you refer to the IDSR, you see that that is not the structure. So for the test being done there, it qualifies as what? As an in-house testing, and you are able to update the result. If we have to also configure so that they as a lab can put in results there, that can be done. But we'll see that that arrangement is to give a quick turnaround at the regional level. And we still have the structure to take our samples towards the Tamale reference lab, where the standard testing for confirmatory testing should be done. So that is one of the things that we want to understand. So for instance, the teaching hospitals typically have capacity to do a lot of these in-house tests and all that. But we know that for the result to be taken internationally, we have agreed on the standard lab that should do what per each disease. So let us still follow that, and then let's see how it works. So I think with the input that you have made, the regional team, the disease surveillance department team should have a discussion, and then we see what works for us. The whole idea is to use this system to make the work easy. So it's a discussion that can be had, and then we take the best decision that makes the work easier and facilitates what we are trying to achieve in surveillance. Thank you very much. Bruno, please go on, and then we can take Livingston and then Abdul Basit, and then we can end our session. Alunga Bruno. Okay, so Livingston Aite, please go ahead. Okay, yeah, okay. I see a question about configuring e-tracker tablets. So the SORMAS app is available with our regional and district disease surveillance officers. If you take the tablets there, they should be able to help you to install them. As I mentioned, it's an integrated system. And so if disease surveillance department bought a tablet, we would not say only use it to run SORMAS. Yes, put the SORMAS on it, use it. And if there is any other system the Ghana Health Service has put in place to support the work that the service wants to do, definitely you want to be able to do that. So our district and surveillance officers are in a position to help us to do this. Livingston, please go ahead.
Okay, thank you very much. Please, I wanted to find out, for example, I am working in Aison, the district health directorate. In an attempt to teach somebody how to use the SORMAS, maybe I want to teach one of our sub-districts or those who are in charge of surveillance in the various facilities how to use the SORMAS. Obviously, I will use the live SORMAS, let me say, workstation to teach the person. Okay. Now, how do I delete it? Because it's not a case. Okay. It's a trial system that I'm using to teach the person. Okay. Because when you go back and you clear everything, still, the name of the case is still in the system and it will be added to the part. Let's say, for instance, I used measles. It will be added to my measles case that I have entered one measles, but maybe it's 10% or 5% complete. So if maybe a trial website can be created in which if we want to teach our facilities, we can use that site to teach them, and then the live will be used for actual cases. And then if maybe I have that case, how do I delete it from the system? Thank you.
Okay, thank you. So that is also available. There's a training server. So all the trainings that we do and all that is actually done from the training server. So this can be done. Normally, when you are doing on-the-job training, encouragement is not to just create a case out of the blue. You may actually have a measles case. You may actually have a yellow fever case. You may actually have an AFP case. So use your real case to actually do the demonstration, because we don't keep the training server open at all times so that people don't just abuse it. Remember, it's also a resource. So normally by the time you are wanting to do some on-the-job training, we may not be able to open the training server just for you. But if I actually have a case, then I want to use that case to teach. For me, that would be the best way to approach that on-the-job training. We have the formal trainings at the district level, facility level, regional level. We use the, how do you call it, the training server. So this is available. It is just that it is not always open for use. It is not the most efficient way to use it. So that is what I can say about the situation that you described. Bruno, please go ahead.
Yeah, thank you very much, Doc. I have I think when I moved to Sagnarugu, I think the latter part of last year, Mr. Obed came around, and we have 2 military facilities, ABF and 6 MRS, and they are sentinel sites for influenza, influenza-like illness. I think they passed by and made me to understand when the data is entered into SORMAS, we are supposed to enter it into DIMS. So I think I contacted the facilities and they brought up a suggestion. They were asking whether it's not possible to synergize the system such that when they enter it into SORMAS, it automatically reflects into DIMS. So I think I just wanted to find out if that is possible or if that will be possible in the nearest future. So what I did was that I contacted their focal persons to give me their contacts so that whenever they enter into the system, I think they have challenges with entering into DIMS. They will give me the information so that I will enter it at my end here into the DIMS. So I was just trying to find out if that will be possible or if it is possible in the nearest future. Because they were complaining that it looks like to be double work to enter it into SORMAS and enter into DIMS at the same time. Yeah. So
Thank you very much, Bruno. So that is also a very important concern. The service has already identified this need. Work on it has been started. And so we are hoping that over time, we can get this interoperability, as we call it, done. And then that would clearly make it easier. So it is something that, yes, as you rightly said, it's important to do, and work has already started on it. So we hope that in the near future, sooner than later, this would be achieved. And then we can all focus on the flow of our work as you rightly described. So I see Abdul Basit. We'll take Abdul Basit's question, and then we will begin to wrap up and set the tone for our next meeting.
Okay, thank you very much, Doc. I'm Abdul Basit Abdullah from the Nuba Sub-District, Northern Region. Mr. Obed, my regards. Our class is proud of you. Now, my question, under what circumstances can a district transfer a case to another district in SORMAS? And if this can be addressed alongside this question, there are many surveillance officers are still confused on what a case for a district is. For example, if in my district, a client goes to a different district for maybe care, and then from there, they suspect a case, and during investigation, the case indicates that, oh, I'm from a different district. Then most surveillance officers take it that this is not my case, though they are doing the suspicion, doing the investigation, and even sometimes even number it as the one of their EPID numbers. Yet they consider, when it comes to reviews and then what do you call it, and data analysis, they consider it to be a case for the district where the person or the client is coming from. So if that can be clarified once we are dealing with surveillance, alongside my first question, under what circumstances should a district refer or transfer a case in SORMAS to another district for what do you call it, continuous services? Thank you.
Thank you very much. Interesting and topical question. So I see two arms to your question. One is a surveillance question, and one is maybe somebody will say an IT question. I think we would also have a session where we demonstrate how to do a case transfer on the SORMAS system. So that is not what we'll focus on. The other one is a surveillance question. And I think, as we mentioned, SORMAS is not telling us how to do surveillance. How we do surveillance is something that we've all learned. We've got the technical guidelines and the basic principles of surveillance to guide us. So sometimes it is on, for want of a better word, self-interest, isn't it? Because I have made this point where we all fight to keep an AFP case, but we'll be very quick to push any other case to another district. Why does it happen like that? Is it a principle we are using, or it's more about our self-interest? So we should not even have confusion about the fact that we are reporting on cases we have detected. So where was the detection done? And that is where the discussion starts. where was the detection done? But public health investigation and actions also take into consideration where the case may be coming from, resides, and all that. So we don't want to confuse the two things, and that is why the work is collaborative. We really need to enhance our understanding of those issues. So clearly, when I detect a case, I report it. It is my case as a district. I'm not going to push it to somebody because of where the case resides. So how about when the case works in a different district, spends up to 8 hours of the day in that district, resides in a different district, spends up to another 8 hours sleeping in that district, and has come to another district? Which of the, is it the workplace district will send the case to all the resident districts? No, we have detected the case, but we will collaborate with our colleagues in these two different districts because we appreciate that the public health actions has to involve our colleagues in these two other districts because of the activities the case have been engaged in prior to detection. I don't think that we are here to, as it were, teach the principles of surveillance. So we need to understand this. I understand where this question is coming from. And clearly the way my colleague is asking the question, you can see that it is very dear to the heart. And sometimes maybe, as I'm saying, it's more from self-interest and not that we don't understand the principles underpinning the way our practice is supposed to go. So thank you for that question. But as we said, if there is a clear indication that I have picked on a case and it wasn't my facility that detected it, then we should see how we are able to transfer the case. That one will be covered on the system. Once we get to those sessions, we will show how it is done. Thank you very much. So today we want to pause our session here. We would have an in-house discussion, and then we would quickly communicate when our next session will be. We will try and make it as soon as possible so that we can take on the other issues of maybe contact creation, maybe go a bit more into detail with the sample creation and barcode use, and then also show how we use the web interface for the supervision and all that. Because if we want to continue, we may take the whole day and we will not finish. The issues of SORMAS clearly are a lot. So with your indulgence, we may pause here, and then we may invite Dr. Lai if he has any last comments and encouragement for us to wrap us. Please look out for your emails. We will be sending a survey and also some other material via email to all of you that joined us here today. And you can always go back to YouTube and replay this session if any of the steps were not too clear to you. Dr. Lai, please, if you are on, you can.
Okay, thank you very much. So I was trying to unmute. I think you had blocked the rest of us from being able to talk. Thank you very much. I've really followed the discussions, and I've also looked at the comments and the discussions that have followed. I have to say that I'm very happy that we had this, and it's just the beginning as we've indicated. I'll touch on a few things. I think some of them were very interesting. But as I said, our key objective to get us talking about SORMAS, to raise some of the issues around SORMAS and how to make it better, have definitely come up, and I'm very happy with that. I know one of the last things we discussed or came up was the issue of SORMAS DIMS integration, and I think Dr. Atta has touched on that. It's very important for us. I would ask, especially those of us who have access to district and regional level data, to look at various priority diseases that we have in SORMAS and compare that to what we have in DIMS. And we will see that there are very significant differences. Indeed, there are even some diseases we haven't diagnosed, but they are in SORMAS. And so it's important, this DIMS integration with SORMAS is a very critical thing for us. And it's also one of the reasons why in this session we targeted disease control officers and health information officers, because we know that the bulk of the people working on DIMS are health information officers, and the bulk of people working on SORMAS are disease control officers. And we want the two of us to be speaking to each other and knowing where the gaps are and what we can do to address. And I think one of the speakers was highlighting how he's been doing this. So please, let's, for starters, as I said, start comparing, whether it's at our district or our facility level. Let's look at the two data sets. In SORMAS, if you take AFP, for example, how many do you have in SORMAS? Is it the same number in DIMS? Because they are supposed to be the same. So whilst we work at interoperability, I want us to do this manually for now. I've also noted a concern about deletion, the capacity to delete at the lower levels. There are pros and cons, and I think that we'll engage with our respective DDPHs on this and come to a firm conclusion. Deletion of data that has been entered must be done with a lot of consent or consideration, I should say. And so it should not be such that it can just be done. And we have to put in mechanisms to make sure that if it is sent to the subnational level, it's not abused. But the other thing, I was not sure. I think OT RSO brought that issue up, that sometimes it stays in the system for a while. I'm not sure if the team in my department have been delaying in deleting this, but I think that some of these things would need some very further and better particulars, as the lawyers like to say, so that we can be able to address them well. I don't think that data entry errors are so rampant that it is going to overwhelm the system. But as I said, we'll have to look at how to make it easier at the lower level. I think Dr. Atha also pointed out something, which a lot of the times when technology comes in, we sometimes fall victim to, which is the fact that we assume now that the technology is a new thing. And so it is taking over everything we are doing. It is not. And I've had this experience with our colleague doctors as well in AFP surveillance. So I know that sometimes we struggle to make that distinction or get the point that this is just facilitating our work. It is not taking over our work. So if in the era of paper-based surveillance or case-based form use, if, for example, we had a case from another district, what would we have done? SORMAS should facilitate that process. SORMAS should not stifle what we would have done in the era of paper-based surveillance. So that's one thing I want to add. And as has been indicated, some of these things, how to transfer to another district and the other things will be done in subsequent sessions. And so we'll be able to pick those ones and be more confident in making SORMAS facilitate our work rather than become an obstacle. I also noted in the chat the Allied Health CPD credit. Look, let me assure you, we'll have so many of these sessions, you will get more than enough CPD points than you will need for the year. So let's not be so worried about CPD points, but rather let us focus more on making sure that what we intend to teach or learn here is grasped very well so that we can be able to use these to our advantage. And the issue about automation, pop-ups, and the likes. Again, like I said, you see, in the past, we were waiting for emails that took forever to come. And even that, we worked. Now there's a platform where you just have to log in and you can find the results. And we want a pop-up. So I guess we are being spoiled now because it's easier and we are getting more convenience. I don't want us to be so fixed on getting things so convenient that we leave some of these critical practices out. For example, as a district surveillance officer or as a facility surveillance officer, it should be one of the things you do when you get into your office every day. Log on. What has come in the course of the day or at the end of the day, log in. We will get to the point where, as we said, all these alerts and the other things can come in. But if we don't also actively look for it now, because I think the colleague who was making that point actually said that we needed to act urgently. And so it's important that we get this. So if we also understand the urgency, then we should also be logging in. So it's a two-way thing. Whilst we at headquarters are doing the best we can to facilitate your work, we also want you, our colleagues at the lower levels, to also be proactive with some of the things. And I'm sure that by the time we go through the whole spectrum of activities we've planned as far as this, as SORMAS is concerned, and especially when the new form comes in, because I know there were some concerns also raised along the line that a lot of the variables there are redundant. And so why are we keeping them there? The new platform would not have those challenges. But until then, I would ask that we try and make the best of what we have. Issues around barcodes, I think Obed highlighted it, the need to avoid manual entry because we can make errors. And if we do, then it means that the sample will get to the lab, but we can't pick it. And so it's very important that we pay attention to some of these little fine details so that we can be able to do this. At some point, we're over 720 on the call. Now we are about 500. So I think that some have fallen off. Some are tired. Some may have other pressing issues they will attend to. We will try and make sure that we duplicate these or even triplicate these sessions so that it can be suitable and convenient for everybody to join. So on behalf of the Director of Public Health, Ghana Health Service, I want to thank you all. I know colleagues from teaching hospitals, CHAC facilities, and Ghana Health Service facilities all joined in this call, and we are grateful for the time. Thank you very much, and over to you, Dr. Atta and the team. And let me also thank you to my team. If I don't thank you, I don't think it will be appropriate because you've done a very good job, Obed and all colleagues. Thank you very much and have a very good day. Over to you, Dr. Atta.
Thank you very much, Dr. Lai, and we thank our colleagues for spending 3 hours of a Friday morning with us here. We are very grateful for your attention. And I think I see that someone is asking for in-person. Yes, I think the slide that we showed, we see that it's a mix of approaches. So we'll be doing these online sessions, we'll be doing in-person trainings, but you can see there was no way we could have fitted 700 people into a session like this. So that is why we are adopting this approach so that at least it would quickly bring us up to speed and in a very efficient manner. But the in-person sessions will be following up. And then as we have also shared our email addresses and we have made it clear, our district and regional surveillance officers, they have a lot of knowledge about the system. Please, let's work with them. Let's get closer to them. And they have done this with us for a long time. So a lot of times you can see that they are the fast track to get to our surveillance team and IT team here. The system is about surveillance. So we are here to support you as we go ahead. We will get over this all. Thank you all very much. So at this point, we would officially end the session. We will leave the system running for a few more minutes, and then we would end it. Thank you all very, very, very much for your time.